Today's episode is sensitive. It is about marriage, love, depression, bipolar disorder, psychiatric illness, family involvement, safety, boundaries, and the difficult question: how do you love someone who is suffering mentally without losing yourself? How do you protect the marriage without pretending that love alone can treat illness? How do you help your partner without becoming their doctor, their therapist, their parent, or their emotional punching bag? And how do you stay compassionate, legally careful, and personally safe? Today's episode is called When Your Partner Has Depression or Bipolar Disorder, Can Love Survive Mental Illness? Let us begin with today's situation. A woman writes, "My husband is a good person. Deep inside, I believe he loves me. When he is stable, he is kind, intelligent, affectionate, and emotionally connected. But there are times when he becomes a completely different person. Sometimes he becomes deeply low, withdrawn, hopeless, silent, tired, and disconnected from everything. At other times, he becomes unusually energetic, restless, angry, impulsive, overconfident, and impossible to reason with. He may spend money carelessly, sleep very little, talk too fast, make sudden decisions, or become suspicious and irritable. Then later, he may crash into guilt, sadness, shame, and exhaustion. I keep wondering, is this depression? Is this bipolar disorder? Is this his personality? Is this illness? Is this abuse? Is this something beyond his control? I love him. I want to save the marriage, but I also want to be safe. I want to do the right thing medically, emotionally, legally, and practically. How do I handle this? This is one of the most difficult situations in marriage, because when a partner has a psychiatric condition, the spouse often lives in two realities at the same time. One reality says, "This is the person I love." The other reality says, "This situation is hurting me." One reality says, "He or she is suffering." The other reality says, "I am suffering too." One reality says, "This may be illness, not intention." The other reality says, "Even if it is illness, I still need safety, respect, and boundaries." Both realities are true, and mature love must be able to hold both. Let us begin by understanding the conditions. Depression is not simply sadness. A person with depression may lose interest in life, feel emotionally heavy, sleep too much or too little, lose energy, lose motivation, feel guilty, feel worthless, become irritable, withdraw from loved ones, lose appetite or overeat, struggle to concentrate, and feel that even normal life requires enormous effort. There are different types of depression. Major depressive disorder is what many people think of when they hear the word depression. Persistent low mood, loss of pleasure, low energy, and difficulty functioning. Persistent depressive disorder is a more chronic, long-lasting low mood that may not look dramatic from outside, but can quietly affect the relationship for years. Postpartum depression can happen after childbirth and may deeply affect mood, bonding, sleep, anxiety, and family life. Seasonal depression may worsen during certain times of the year. Depression related to grief, trauma, medical illness, alcohol use, substances, sleep deprivation, hormones, or medications may look similar but require careful medical evaluation. And then there is bipolar depression. This is very important. Bipolar depression may look like ordinary depression, but it belongs to bipolar disorder, where the person also has episodes of mania or hypomania. This distinction matters because treatment choices can be different. Bipolar disorder is not just mood swings. Bipolar disorder is a serious mood disorder where a person may experience episodes of depression and episodes of mania or hypomania. In bipolar I disorder, the person has had at least one manic episode. Mania may include unusually elevated or irritable mood, very high energy, reduced need for sleep, racing thoughts, impulsive behavior, grand plans, risky decisions, increased spending, intense anger, poor judgment, or feeling unusually powerful or invincible. Sometimes, mania can become severe enough that the person loses touch with reality, becomes paranoid, or needs urgent medical care. In bipolar 2 disorder, the person has depressive episodes and hypomanic episodes. Hypomania is less severe than mania, but it can still damage relationships, finances, work, trust, and stability. A hypomanic person may seem charming, energetic, creative, confident, and productive, but they may also become restless, irritable, impulsive, sexually inappropriate, financially careless, or emotionally unavailable. Cyclothymia involves repeated mood fluctuations that may not fully meet the criteria for major depression or hypomania, but still create instability. As a spouse, what do you encounter? You may encounter emotional whiplash. 1 month, your partner may be loving, hopeful, and engaged. Another month, they may be unreachable, silent, or hopeless. Another time, they may become intense, restless, argumentative, overconfident, or reckless. You may feel like you are married to different versions of the same person. You may begin walking on eggshells. You may monitor their sleep, tone, spending, energy, messages, and mood. You may become the family detective. You may feel responsible for preventing the next episode. You may feel guilty for getting tired. You may feel angry, then ashamed of being angry. You may think, if this is illness, am I wrong to feel hurt? No, you are not wrong. Illness explains behavior. It does not automatically erase its impact. Compassion for your partner must include compassion for yourself. Now, let us make a very important distinction. Psychiatric illness is not a moral failure. A depressed partner is not lazy. A bipolar partner is not simply dramatic. A manic partner is not always fully aware of the damage they are causing. The brain, sleep, mood regulation, judgment, impulse control, stress response, and emotional interpretation can all be affected. But this is equally important. Mental illness is not a free pass to harm a spouse. It does not remove the need for treatment. It does not remove the need for accountability. It does not remove the need for safety. It does not remove the right of the spouse to set boundaries. You can say, I understand this may be illness, and I still need us to get help. I love you, and I cannot manage this alone. I care about you, and I will not accept unsafe behavior. I want to protect this marriage, but treatment has to become part of our life. This is not betrayal. This is mature love. Now, what should you do first? Step 1. Stop diagnosing your partner alone. As a spouse, you may notice patterns, but you cannot safely diagnose depression, bipolar disorder, personality problems, trauma, substance-related mood problems, or medical causes by yourself. The correct first step is professional assessment. A psychiatrist is important because bipolar disorder often requires medical treatment. A counseling psychologist or clinical psychologist is important because the couple and family need emotional skills, communication tools, psychoeducation, and relapse planning. In many cases, the best approach is a team, a psychiatrist for diagnosis, medication, and risk assessment, a psychologist or therapist for individual therapy and couples or family work, a primary care doctor to check physical health, sleep, hormones, medications, alcohol, substances, and other medical contributors, and, when needed, a lawyer or legal advisor if there are safety, property, custody, immigration, financial, or documentation concerns. This does not mean you are making the marriage legalistic. It means you are being responsible. Love without structure can become chaos. Step 2. Choose the right timing. Do not try to have a deep psychiatric conversation when your partner is severely depressed, extremely agitated, intoxicated, sleep-deprived, manic, or in the middle of an argument. Timing matters. The best time to talk is when your partner is calmer and more reflective. Use gentle but clear language. You might say, I love you, and I want our marriage to survive. But I am noticing patterns in your mood, sleep, energy, anger, and sadness that are bigger than ordinary stress. I do not want to blame you. I want us to get professional help together. Or, I am not saying you are the problem. I am saying the pattern is hurting both of us. We need support. Or, I will come with you. We can start with a psychiatrist for assessment, and then also work with a psychologist or counselor for the relationship side. The tone should be calm, not accusing. The message should be firm, not vague. Step 3. Document patterns, not insults. This is important medically and legally. Do not write emotional accusations like, "He is crazy." "She is impossible." "He ruins everything." Instead, document observable facts. Sleep reduced to 3 hours for several nights. Unusual spending. Sudden major decisions. Extreme irritability. Withdrawal from work or family. Not eating. Not bathing. Talking unusually fast. Intense suspicion. Refusal of medication. Aggressive language. Leaving home suddenly. Risky driving. Threats. Hospital visits, medication, changes, alcohol or substance use, dates, times, examples, and impact. This helps the psychiatrist understand the pattern. It also protects you if later you need to explain what happened to family, doctors, employers, lawyers, or authorities. Documentation is not revenge. Documentation is clarity. Step 4. Involve family carefully. This is delicate. Mental health is private. A spouse should not casually expose the partner's condition to everyone. But serious psychiatric instability is not something one spouse should carry alone. The goal is not gossip. The goal is support, safety, treatment adherence, and crisis planning. When possible, involve family with your partner's consent. You might say, "I do not want to embarrass you, but I cannot manage this alone. Can we choose one trusted person from your family and one from mine who can support us respectfully?" Choose people who are mature, discreet, calm, and solution-oriented. Do not involve people who are dramatic, blaming, shaming, violent, financially manipulative, or likely to worsen the situation. The family support circle should be small. Maybe one sibling, one parent, one trusted elder, one close friend. The role of family should be clear. Help the person attend appointments. Support medication adherence when prescribed. Reduce shame. Help monitor warning signs. Support the spouse. Help during emergencies. Avoid blame. Avoid public exposure. Avoid pressuring the couple into silence. Avoid treating the illness as a family scandal. In many cultures, families either hide mental illness or overreact to it. Both can be harmful. The mature approach is privacy with support, compassion with structure, respect with safety. Step 5. Create a relapse plan. When your partner is stable, sit together and create a written plan. This plan may include early warning signs of depression, early warning signs of mania or hypomania, sleep changes, spending changes, irritability changes, withdrawal signs, medication warning signs, emergency contacts, doctor contacts, family contacts, what the spouse is allowed to do if symptoms return, what financial protections are needed, what decisions should be delayed during unstable mood episodes, what to do if the partner refuses help. When hospital assessment may be necessary, a relapse plan should not be created during crisis. It should be created during stability. Because when the mood episode comes, insight may reduce. The person may deny they are unwell. They may say, "I am fine. You are controlling me. You are the problem. I do not need treatment." That is why the plan must be made before the storm. Step 6. Protect sleep. In bipolar disorder, sleep is not a small lifestyle issue. Sleep disruption can be a major warning sign and trigger. If your partner begins sleeping very little but has high energy, becomes unusually talkative, impulsive, irritable, or overconfident, Take it seriously. A stable routine matters. Regular sleep, regular meals, reduced alcohol, reduced substances, stress management, medication adherence, predictable daily rhythm. This is why some therapies for bipolar disorder focus on social rhythm and routine. Love is emotional, but bipolar stability is also biological. The marriage cannot be saved only through conversation if the illness is not medically managed. Step 7. Separate the person from the illness, but do not excuse everything. You can say, "This is the illness speaking," but also, "This behavior needs treatment." You can say, "I know this is not your best self," but also, "I will not accept being threatened or humiliated." You can say, "I believe in us," but also, "We need professional help." This balance is essential. Too much blame creates shame. Too much excuse creates danger. The mature middle is compassion plus accountability. Step 8. Take care of yourself. The spouse of someone with serious depression or bipolar disorder can become exhausted. You may develop anxiety, insomnia, resentment, hypervigilance, and emotional burnout. You may stop seeing friends. You may hide the truth from family. You may protect your partner's image while silently collapsing. This is not sustainable. You need your own support. A therapist, a trusted friend, a family member, a support group, a doctor, a spiritual advisor, if that is part of your life. You need sleep. You need financial awareness. You need boundaries. You need private space to speak honestly. You are not abandoning your partner by getting support. You are increasing the chance that the marriage survives. Step 9. Know the difference between illness and abuse. This is difficult but important. Bipolar disorder can involve irritability, impulsivity, poor judgment, emotional intensity, and conflict. Depression can involve withdrawal, irritability, and hopelessness. But repeated intimidation, threats, physical violence, coercive control, forced isolation, financial control, humiliation, or repeated violation of boundaries must be taken seriously. Even when mental illness is present, safety comes first. If you are unsafe, do not try to solve it alone through patience. Involve trusted family, professionals, local emergency services, legal advice, or protective services as appropriate.